Good evening, everyone. Myself, Dr. Bharat Kumar Vashne, Secretary, Indian Medical Association, welcomes you all, and especially our speaker, Dr. Sanjeev Gulati, sir. Sir, I welcome you, and on my request, my President, Dr. Vipin Gupta, sir, to kindly proceed further.
Okay, thank you, Dr. Bharat. Dr. Sanjeev Gulati with us today. He is a renowned name in the Delhi and NCR region. He did his MBBS in 1984 from Maulana Azad Medical College, Delhi, MD from PGI Chandigarh in 1989, DNB Nephrology from PGI and DM SGPGI from PGI Chandigarh in 1994. He is also a member of National Academy of Medical Sciences since 2005. He has been ex-president of Delhi Society. He is ex-vice president of Indian Society of Organ Transplantation. He is an ex-member governing body of Indian Society of Nephrology. He is working as an additional professor in nephrology in SGPGI Lucknow. He has worked as an associate professor in nephrology at the McMaster University, Hamilton, Canada. He has post MD experience of about 25 years. Now he is currently working as a chairman nephrology at Fortis Group of Hospital, Delhi and NCR region. He is the secretary North Zone chapter of Indian Society of Nephrology. Now I hand over the session to Dr. Sanjeev Gulati. Please, sir.
Thank you, Dr. Vipin and Dr. Vashne, and good evening, everyone. At the onset, I'd like to thank IMA Aligarh for giving us this opportunity today. Me and my colleague, Dr. Mustaqim, will be talking about chronic kidney disease. And I'll show you over the next few minutes how it is important for each one of us, the diagnosis of chronic kidney disease. Just share my slides, bear with me. Screen share, just a minute.
Okay, sir.
Okay, yeah. Right, so I'll be talking about early diagnosis of chronic kidney disease and the role of the primary care physicians. And Dr. Mustaqim will update you about the various options of stage 5 chronic kidney disease, like dialysis and kidney transplant, as to which one is better. Now, this is a quote from late President Kalam's book, Wings of Fire. And the actual quote is by Alvin Toffler. And it says that the illiterate of the future are not those who can't read or write, but those who cannot learn, unlearn, and relearn. And in that sense, I think the medical fraternity is perhaps the most learned of the lot. And even on Thursday, at 9:30 p.m., most of the other community would be busy either on WhatsApp, Facebook, or whatever you might say. We are all tied here trying to update ourselves and learn from each other about different aspects. Today, chronic kidney disease. Now, what exactly do we understand by chronic kidney disease? So this was the National Kidney Foundation's guideline that if you have structural or functional markers of kidney disease present for more than 3 months. So this could be pathological abnormalities, markers of kidney damage like abnormality in the urine or blood, or imaging tests. So blood abnormalities like raised urea and creatinine, urine abnormalities, proteinuria, abnormalities like of less than 60 mils per minute for more than 3 months. And even if there is no other evident sign, then it still qualifies for chronic kidney disease. And we'll discuss how do we calculate, in EGFR, or what we talk about, what do we understand. Now, but first I remember when I was doing my post-graduation, we were least bothered about chronic. The moment we had a patient of chronic kidney disease, we said, oh, just call in the nephrologist. We don't have anything to do. But this is everyone's problem. For a surgeon, it is important because perioperative renal dysfunction could happen. There could be problems with fluid and electrolytes. And if you have undiagnosed patients of chronic kidney disease, you should avoid NSAIDs. So you need to know what is the kidney function, because if you give inadvertently NSAIDs, the kidney function is going to crash and the patient is going to be very unhappy. The stay is going to get prolonged, might even require few sessions of dialysis. For the anesthetist, again, he needs to be sure about what the fluid and electrolytes are, whether how much of potassium needs to be given, whether there is some metabolic acidosis, how much of fluids are given. For the physician, obviously drug dosing depends on the percentage kidney function. Obstetrician, and I'm sure there'll be some in the audience today, the outcomes of pregnancy as well as the neonatal outcomes are directly related to the degree of renal dysfunction. For the radiologist, if or she is administering contrast, they need to know the kidney function. Otherwise, this patient could have contrast nephropathy. For the intensivist, again, fluids and electrolytes, drug dosing. For the cardiologist, again, before subjecting these patients to angiography, inadvertent contrast nephropathy would happen if we do not know what is that the kidney function is normal. So we need to. So for each one of us, I think it is important to know whether this patient has chronic kidney disease or not. And I'll show you how it's very simple today to diagnose CKD. But first of all, I'll share with you certain patients. These are real life patients that I've managed over the last few decades. This is a 44-year-old lady who was a school teacher in Delhi Public School, Vasant Kunj. So, and she presented to our emergency in 2007 with breathlessness and accelerated hypertension. When we went back into the history, in 2003, there was history of severe hypertension. At that point of time, other than a non-invasive cardiac evaluation, nothing much was done, and she was put on a atenolol and pretty much forgotten until she came to us in 2007. At that point of time, when we looked at her in detail, we found that the creatinine was 8.4. She had ultrasound shows bilateral contracted kidneys, and to her horror and surprise, she indeed had stage 5 chronic. Got her into a kidney transplant quickly, and as you can see, this is slightly old. Today is 2021, 14 years post-transplant, normal kidney function, serum creatinine of 0.8, triple drug immunosuppression. Not only that, she actually did a PhD after this, and now is teaching in a college in Agra, and just come to us every few months for a visit. So this is what optimal management of chronic kidney disease can achieve today, the quality of life that we can give to these patients. But often she used to ask me that could something have been done earlier, and the unfortunate answer is yes. In 2003, if somebody had been a bit more careful and looked at her EGFR, I'm sure we would have added years to life and life to a years also. Another patient which we saw a few years back, a 50-year-old diabetic for last 7 years. I'm sure all of you would have seen such patients. History of filling of feet, diminution of vision, headache, blood pressures of 180 by 110, had anemia, peripheral edema, hemoglobin of 9, serum creatinine of 4.4, EGFR of just 22 mils per minute. And this patient obviously had diabetic kidney disease. So this patient could present to a surgeon with the right inguinal hernia, could develop acute gastroenteritis, worsening of underlying kidney functions, could have chest pain and presenting to a cardiology for angiography, abdominal pain requiring a CT scan, contrast. So it is imperative that before, we always, just like you take the demographic of a patient, that what is his age, what is the gender, what is the occupation, we also should record today in 2021, what is the EGFR, and we'll tell you more about this. This is another patient, a 63-year-old male, diabetic for 9 years. This was admitted in our hospital with edema, blood pressure under a physician, blood pressure of 130 by 80, and he had done a urine albuminuria, which was negative. He had done a serum creatinine, which was 1.3, ultrasound showed normal sized kidneys. And he wanted to find, he just couldn't explain the edema, so he asked us to have a look. And the question is, does this patient have chronic kidney disease, to explain the edema? Mind you, the heart had been obviously looked at. So I'll we have divided our talk today into two parts. I'll be talking about early diagnosis and chronic kidney, how we look at clinical kidney function tests, clinical approach, and Dr. Mustaqim, who's a junior consultant with us, will talk about options for renal replacement therapy. So, simple tests that can diagnose chronic kidney disease. Simplest test is still the urine analysis. If you have a specific gravity of 1010 in a first morning specimen, that tells you that this kidney is not concentrating the urine, and the loss of concentrating capacity is one of the earliest abnormalities that we see. Proteinuria is again a hallmark of renal disease, and a good urine sediment examination, if it shows RBCs and RBC casts, it is a glomerulonephritis, WBCs and WBC casts, it is pyelonephritis, broadcast chronic kidney disease. But most or more often than not, we see patients roaming around with the urine reports saying NAD. And I think in my practice, if there is one specimen that is treated with disdain, it is the urine examination. It is kept in one corner. Sometimes it spills off, but since you have taken the sample, you are forced to give a report. It is examined hours after it was collected, so most of the sediment is gone. That's why during our residency days, if you have time and if you are not able to figure out difficult patients, I would suggest that at least do a urine examination yourself. There is something I am interested in, and then they will give some respect, and that's what we do in our hospital, despite a pretty busy practice. That I tell my pathology colleagues, look, this is one urine I would like to see for myself with you, and they oblige us. So this is this next step after a simple urine test is a urine albumin quantification. And earlier on, we used to do 24 hours collection, but it's, I think, one of the most difficult tests to do. If you don't believe it, try collecting urine for 24 hours yourself, and you'll see. But now several studies have shown that a spot urine albumin creatinine ratio, if done accurately in the first morning specimen, correlates very well. So a normal value is less than 30 milligram per gram, which correlates with a 24-hour urine excretion of protein albumin of 30. 30 to 300 is microalbuminuria, and more than 300 is overt proteinuria. So you don't have to burden your patient with a 24-hour collection. And if you do find microalbuminuria, well, confirm it at least 3 times over a period of 6 months, because simple things like fever, heavy exercise, or an infection like UTI can cause microalbuminuria. And as we all know, it's a hallmark of early diabetic kidney disease. It also helps us in staging chronic kidney disease, and we'll come to it again later. The third set of tests, as we all know, it is urea and creatinine, and for a long period of time, at least during my residency, we were told that it is the gold standard for diagnosing chronic kidney disease. Now, this chart will tell you that what all along we have believed was 24 karat gold was not really so. This is the serum creatinine values, and this is the GFR. So GFR will taking you back to your physiology days. This is the most accurate way to talk about kidney function. Normal GFR being about 100 to 120 mils per minute. And as you can see, this is the GFR that is declining. These curves are showing you. And this is the creatinine. It is only when the creatinine value starts rising when the GFR falls below 60. So this is somewhere around 1.2, 1.3. So what I'm trying to say is between 120 to 60, if a patient is coming to you with a GFR of 120, 60 to 120, and you are just doing a serum creatinine, you're going to miss kidney disease. And the urea actually rises even much later. So this is 40 milligram, which is the normal urea, somewhere around GFR of 30. So today, if we have to talk about a kidney disease, we need to know what is the eGFR or estimated GFR. And this will tell you. So I picked up 3 patients with same serum creatinine. A 24-year-old man with serum creatinine of 1.3, 63-year-old man with a 1.3, an 80-year-old lady with serum creatinine of 1.3. And GFR is now calculated by the CKD EPI equation. So we'll see what their GFRs are, eGFR. So 24-year-old man, GFR is more than 60, and there is nothing else. like normal urine. If there is no proteinuria, ultrasound is normal, then you can give him a clean shit. But a 63-year-old man, the same serum creatinine with the EGFR is just 59, and if you have done it twice was 3 months period, then this patient has chronic kidney disease, and this is actually case number 3 that I just showed you. So what we did in that patient was we asked him, okay, we'll just repeat it, a month later, and indeed the serum creatinine was 1.3. So this patient actually, who was referred by a physician friend, had stage 3 chronic kidney disease, which was causing the edema. An 80-year-old lady with the same serum creatinine of 1.3, the GFR works out to just 42 mils per minute. So that's why we don't, talk about serum creatinine values nowadays. Now, all of you would be wondering that, who's got the time and how would I calculate? Well, this you should all download on your cell phones today or even on your desktops. And even before you enter, your paramedical help there can actually, put in these values, like in this medical GFR master, you just put in the age, body weight, serum creatinine, and it gives you the GFR. And you can write up the EGFR for you by the time the patient is coming in. Or you can do it for yourself on your calculator. Now, this is the other thing that is new. What we also look besides the EGFR is the degree of proteinuria. So these are the different GFRs, and this is how we classify chronic kidney disease into 5 stages. G1, G2, G3 is divided into 3A and B, G4 is and G5 depending on the GFR. And to add to that, we also look at the microalbuminuria. So it could be mild, normal to mild, it could be moderate, it could be severe. And the green shows LR means low risk of developing chronic kidney disease. So green is low risk, yellow is moderate risk, orange is high risk, and red is actually a very high risk. So these are the patients who are going to end up, the red ones for sure, and orange ones most likely, who are going to end up with stage 5 chronic kidney disease. So you can immediately prognosticate, warn your patient, and he'll take you much more seriously, take your advice much more seriously. If you tell him that, you are at a high risk for dialysis or transplant. So this is the patient I was telling you, 63-year-old man, diabetic for 9 years, creatinine of 1.3, EGFR is just 59. So we reconfirm this, and this patient has chronic kidney disease. Now, large part of chronic kidney disease is asymptomatic, and this is a study that we did in the Fortis hospitals. We picked up charts of our patients, 774 patients over 6 months who had come for a preventive health checkup. So these were self-mandated by their employers. These patients considered themselves healthy. And when we looked at back and did their EGFR calculation, 74, nearly 10% had asymptomatic chronic kidney disease. So they had come in and gone back without seeing a nephrologist, and probably most of them were unaware that they had chronic kidney disease. Ever since then, now in Fortis, where in our labs, we have mandated automated EGFR reporting, so that if you ask for a serum creatinine, you'll get an automated EGFR, which is what we should tell most of our laboratories to do. So this is the distribution of these patients. 7.4% had stage 3 chronic kidney disease, 0.9% stage 2, and 1.3% of the asymptomatic patients had stage 1 chronic kidney disease. None of them had stage 4 and stage 5, because these were asymptomatic people, healthy people, but it tells you the load, at least even in the so-called asymptomatic people, roughly about 10%. But if you include the others, 4 and 5, the symptomatic patients, anywhere between 15 to 17% of people would have chronic kidney disease. So out of 100 patients that we are seeing in the clinic, if you do a EGFR calculation, about a rough guesstimate is about 15 to 17% have chronic kidney disease. So once you have established a diagnosis, what do you do? Let's see. So are there any warning signs of chronic kidney disease? Well, high blood pressure can sometimes be the only sign of chronic kidney disease, especially in young individuals under 35 years of age. The conventional belief is the moment you have high blood pressure, the patient rushes to a cardiologist. But then there you are treating the effect of high blood pressure on the heart, whereas the kidney is involved in regulation of blood pressure in natriuresis, and kidney is the culprit, especially in younger patients. So always do not forget to look at kidney functions and always involve the nephrologist. If you have protein or blood in the urine, yes, obviously you have some kidney disease. Creatinine and blood urea nitrogen test outside the range. EGFR less than 90 with or without with any abnormality in the urine or ultrasound. Symptoms like more frequent urination are non-specific, can be due to just prostate, and also come very late. Puffiness around the eyes, swelling of hands and feet could be there in a heart disease level. So symptoms are late and they are non-specific, and that's why we never depend upon symptoms to make a diagnosis of CKD. And let's talk about this. So how do we know that this patient, if you have a patient, he has chronic kidney disease? Well, if the GFR declines below 100 to 25, along with the spot urine albumin creatinine ratio, and thereafter you stage this patient into one of these various stages. And this is a very good study from Lancet in 2008, looking at nearly 500,000 individuals, more than 20 years follow-up of more than 13 years. This was a study from Korea, and they found that nearly about 12% had chronic kidney disease. Only 3.5% of the participants were unaware of their disorder. But what was actually surprising was that there was a higher mortality for all cause, 100% of cardiovascular disease in this patient population who had CKD. So it is not uncommon in the general population, and even in other countries, the diagnosis is being missed. This is a study from Italy. Again, CKD prevalence of 23%, but a physician diagnosis made only about 4% because everybody was looking at serum creatinine values. Not only that, the blood pressure control, which is I think one of the most important things that we can do to slow down progression, was there in about stage 1 to stage 2, 11%, stage 3, 13%, stage 4, stage 5, 10%. That's why I think there's a lot we can do, to increase the awareness, increase diagnosis, and optimize management. And this is the importance for the cardiologist. So as you see, the lower the GFR, the higher the cardiovascular mortality. So the moment the GFR goes below 90, from 70 to 89, which will be missed, as I told you, if you are making a diagnosis based on the serum creatinine, the mortality doubles. And it's all due to cardiovascular deaths. And below 70, the mortality is 5 times. So if a patient of CKD, these are the patients the cardiologist can be looking at in much greater detail, and subgroup of patients, and thereby improving the life of these patients. A word about CKD and obstetrician. Well, there is the effect of pregnancy on renal function. There is accelerated deterioration of renal function in some patients with chronic renal insufficiency. So that's why before conception, we need to know that, or reassure ourselves that this lady who's planning a pregnancy indeed has normal renal function. The prognosis depends on the degree of renal dysfunction at the time of conception, as well as the presence and extent of comorbidities, namely hypertension and proteinuria. And renal function is most likely preserved if there is mild renal insufficiency. So below 1.5, 16% of these pregnant patients actually had a decline in renal function. 6% patients progress to peripartum end-stage kidney disease. This is a study by Katz et al. So even so-called mild renal insufficiency is not all that benign. Moderate, 20% progress to end-stage kidney disease. Severe, 45% to end-stage. So if you are able to pick up chronic kidney disease, you can warn your patients upfront that you should not opt for pregnancy, and today there are many other options to adapt. Now, why do we need a team approach? Well, this is why we do so, because people think that physicians know everything but often end up doing nothing other than arguing about the diagnosis. Surgeons, in contrast to the physicians, know nothing but try and do everything. And dermatologists are the luckiest of the lot. They know nothing, do nothing, and the patients get better. And pathologists are the most knowledgeable. At least when I was in PGI Chandigarh during my residency, they claimed to be the most knowledgeable, but their knowledge came a day too late. That was only at our CPC or autopsy. Now, when should the patient be referred to a nephrologist? At the earliest, in stage 1 to 3 for planning and management. Because if you give a diagnosis of CKD which is not validated by a nephrologist, I can assure you this patient is going to run away to an alternative therapy practitioner who is going to tell him that he's going to cure him. Always get it validated, and the patient obviously will be followed up with you. There are follow-up with the nephrologist every 3 to 6 months for monitoring, and thereafter, when renal replacement therapy is required, definitely the nephrologist gets involved. So this is the schema of the partnership between the nephrologist and the physician. So stage 1, stage 2, and early stage 3, the primary care physician plays the frontline role. The nephrologist is there at the back confirming the diagnosis, seeing the patient independently. Stage 3B, the nephrologist assumes the frontline role because we have to do vascular access planning, vaccination, other things. But the physician is always there looking at or managing the problem. So it's always a partnership there. What therapy can be offered? Well, first and foremost, we need to control the blood pressure very strictly. We have all along maintained whatever, the JNC has changed over the years, but as far as the KDIGO guidelines, we have been very consistent. We want a blood pressure of 130/80 or even 120/75 if there is proteinuria more than a gram. In diabetes, good blood sugar control. If there's proteinuria, use of ACE or ARBs, correction of anemia, bone disease, and use of statins, because majority of these patients have underlying disease. When to offer dialysis or transplantation? Preemptive transplant if the GFR is less than 10 or there are symptoms of signs of uremia. These are the 3 options. You can, for end stage 5 chronic kidney disease, renal transplantation, maintenance dialysis, and continuous ambulatory peritoneal dialysis. And I'll hand the podium now to my colleague, Dr. Mustaqim, who will tell you about the pros and cons of each one of them. Over to you, Mustaqim. I'll just stop my sharing. Yeah.
Good evening. Let me share my screen. Is my screen visible?
Yes.
Yeah.
Yes,
Okay.
you can proceed.
Okay. Good evening, everyone. I'm Dr. Mustaqim Ahmed Majumdar. I'm Associate Consultant, Nephrology and Kidney Transplant at Fortis Escorts. Thank you, IMA Aligarh, for having this talk, and I am delighted by the presence of esteemed delegates. I will continue the presentation further and talk about the management of end-stage kidney disease. There are essentially 3 options to a patient facing end-stage kidney disease. That is either dialysis, transplantation, or no renal replacement therapy. Patients can start either peritoneal dialysis or hemodialysis and switch between either modalities, and then receive a kidney transplant, or they can also receive the preemptive kidney transplant. So they have to choose between hemodialysis and peritoneal dialysis. Hemodialysis is usually done in center thrice a week, at least for 3 to 4 hours for each session. It can also be done at home, although not common practice in India yet. Peritoneal dialysis, both manual and machine peritoneal dialysis can be done at home. So the indication for acute dialysis, as we all know, are there is a mnemonic to remember the indications for acute dialysis. The 5 vowels A, E, I, O, U. A stands for acidosis, E for electrolyte abnormalities that are refractory to medical therapy, especially hyperkalemia and hypercalcemia, intoxication of various drugs and toxins, fluid overload that is refractory to treatment, and uremia. And the indication for chronic dialysis, there are only few absolute indications for chronic dialysis, and these are encephalopathy, pericarditis, and pleuritis. If the patient has these findings, we have to start maintenance hemodialysis. And the other relative indications are refractory acidosis, electrolyte abnormalities, unmanageable fluid overload, decreased nutrition, cognitive decline, and a specific EGFR. Sometimes if the EGFR is less than 7, then we can consider starting, although it's not an absolute indication. The first modality, hemodialysis. Hemodialysis, currently patients on hemodialysis typically dialyze 3 to 4 hours, 3 times a week, usually in an outpatient dialysis center. They need to have a permanent vascular access. The best is AV fistula. So the option is either AV fistula or AV graft if the fistula is not possible. And the third option is catheters that can be either temporary or permanent catheters. So since fistula is the best option for dialysis access, we should save the non-dominant arm for vascular access when GFR is less than 30 ml, and we should avoid VP measurements, IV injections, and we should not draw blood from that arm. And we should consider placing a vascular access within a year of planning a hemodialysis. The second option is peritoneal dialysis. So in peritoneal dialysis, peritoneal membrane is used as the filter in place of the dialyzer which we use in the dialysis, hemodialysis. And it requires placement of a catheter in the peritoneal cavity to allow fluid to be instilled into the peritoneum and drained out via external port. This has to be done almost 24 hours a day. Now, which is better, peritoneal dialysis or hemodialysis? The factors influencing dialysis choices are, there are certain contraindications for each, either hemodialysis or peritoneal dialysis. And quality of life is better with peritoneal dialysis. Treatment satisfaction depends on the patient, and outcomes, each modality has distinct advantages and disadvantages, and we should explain the patient the specific benefits and risks associated with each dialysis, and there is no conclusive evidence that the choice of PD or HD provides a specific survival advantage. Now coming to kidney transplantation, in kidney transplantation, a donor kidney is transplanted, usually in the right iliac fossa, and the donor kidney vessels are anastomosed into the recipient external or internal iliac vessels. Kidney transplantation is the preferred treatment for patients with end-stage kidney disease. It provides a better quality of life, greater longevity than long-term dialysis, and all end-stage kidney patients should be considered for transplantation. And kidney transplant patients require lifelong immunosuppression to prevent rejection. We should remember that. So there are two forms usually, either live donor or deceased donor. Live donor can be done between related or unrelated donors from family members, spouse, or friend. And there is a new concept called pair exchange. In cases of incompatible donor, the donor organ is provided to the next compatible recipient in exchange for the other donor. Contraindications, there are some absolute contraindication in which we cannot do the kidney transplantation, which includes active sepsis, uncontrolled malignancy, uncontrolled psychosis, active drug dependence, and any medical condition that severely shortens the life expectancy, and a cross-match positive. So evaluation of transplant, there are two main parts of evaluation. One is pre-transplant and one is peri-transplantation. The first thing we have to do is to review the history and look for sensitizing events. In such cases, the risk of rejection increases. The important sensitizing events are transfusion, pregnancy, and previous transplant. The second evaluation is laboratory test, in which we do blood grouping and HLA test. HLA is to look for the antigens that can lead to rejections. Then coming to immunosuppression, there are two forms of immunosuppression, either lymphodepleting or immunomodulatory. We'll discuss about induction therapy later. So first is ABO compatibility. When a person, which blood group can receive what organ? So as we all know, group O is a universal donor and can give to any blood group. And AB is a universal recipient and can receive kidney from all the blood groups. ABO incompatible. Although ABO compatible transplant have better outcomes, nowadays ABO incompatible transplants also confer similar advantages, and the incompatible transplant can be desensitized. Earlier we used to do splenectomy, and nowadays rituximab and plasmapheresis along with IVIG can be used to desensitize, and the outcomes are almost comparable to ABO compatible transplants. The most important test which is done, especially in live donor, is to test the presence of antibodies in the recipient serum to the donor antigens. And if the T cell antigens are T cell cross match is positive, then transplant is an absolute contraindication. So no, coming to rejection, the grafted kidney expresses antigens that are not present in the host, and these antigens are recognized as foreign. The immune system reacts as if the donated kidney is an infectious microbes and attacks the graft. The most important thing to remember is the time frame from the onset of symptoms, so that we can determine the type of rejection and we can treat it accordingly. The usual rejections are hyperacute, which occurs immediately and is very uncommon nowadays because of the careful matching of the donor kidney before transplant. Acute rejection, which occurs in around 15 to 20%, occurs within weeks to months and is treatable in around 90 to 95% of the cases. Chronic rejection sets in after 6 months of transplant, and usually it's very difficult to treat and leads to graft failure. So what are the different modalities of immunosuppression in transplant? So it's basically divided into two forms: induction and maintenance immunosuppression. Induction is done during the early phase of the transplant, that is the first 3 days to 3 to 5 days, which is the window of the graft, window of organ engraftment. After that, maintenance immunosuppression is given. So what is the purpose of induction therapy? Induction therapy either depletes or modulates T cell responses, which are responsible for acute rejection. Therefore, induction therapy reduces the risk of acute rejection. And also, we can decrease the other immunosuppressants if we are using induction. So there are three options. Either we can go with no induction if the transplant is low risk. So what is a low risk transplant? Those who have zero HLA mismatch, they have a live donor and the blood group is compatible, and it is the first transplant. And the other is immunomodulatory, that is basiliximab, and the highest form of induction is lymphodepleting, that is anti-thymocyte globulin, ATG, which is considered in high risk transplantation. For example, those with HLA mismatches and young or very elderly recipients. Coming to maintenance immunosuppression, usually we follow a triple drug immunosuppression, which consists of one CNI or sirolimus. CNIs can be either tacrolimus or cyclosporin. The most commonly used is tacrolimus. The second agent is either MMF, mycophenolate, or azathioprine, and the third is a steroid, that is prednisolone. So triple drug immunosuppression is the most common long-term immunosuppression used in the kidney transplant. The tacrolimus dose is adjusted as per the blood levels, and is gradually, the dose is reduced with time. So which is better, transplant or other two forms of dialysis? So how do dialysis compares to transplant? Dialysis can only do a 10 to 15% of what a normal kidney does. And whereas a transplanted kidney can do 50 to 85% of what a normal kidney does. And people on dialysis have to follow a rigid diet plan, but after transplant, they can eat and drink more freely. And patients on dialysis typically have low energy levels, whereas in transplant, they have more energy and can easily go back to work. Another benefit of transplant is that transplant can add more years to the life of the patient. When we see the survival benefit, so 1 year, 5 year, and 10 year, all patients with living donor transplant have the best survival benefit, followed by deceased donor, and the dialysis patient have the least survival benefit. Another thing is, how long do the patients undergo dialysis before undergoing transplant? So a lot of studies have proved that early stage of pre-transplant dialysis is associated with greatest growth of risk of post-transplant death and death with graft function. So the longer the patient is on dialysis, the poorer are the transplant outcomes. Now coming to the economics of the renal kidney replacement therapy. So when we compare the cost, although transplant costs a lot, when we compare the 5-year cost of dialysis, transplant comes out to be cheaper. So to conclude, the important take-home messages are: kidney transplantation is the most cost-effective modality of renal replacement, and transplant patients have a longer life and better quality of life. Early transplantation, especially preemptive or within 1 year of dialysis initiation, yields the best result. Living donor kidney outcomes are superior to deceased donor kidney outcomes. Early transplantation is more likely to occur in patients that are referred early to nephrologists, and GFR of less than 20 ml per minute per 1.73 meters square is the best time to refer for transplant evaluation. Although there are some adverse effects of transplant, the most common causes of transplant loss is death with a functional transplant, that is usually due to heart disease, which is around 40 to 50% of the cases. And the second is infection, and the third is malignancy. One more downside of kidney transplant is that they have to continue on immunosuppressants for lifelong. And there are some side effects of immunosuppressants that can lead to potential loss of transplant. I will conclude my presentation. Thank you, everyone.
विपिन सर आप
जी, question from any question from the audience side?
सर एक क्वेश्चन मेरा ही है.
हाँ जी,
डॉक्टर संजीव सर.
या
सर आपने बड़ा अच्छा इम्पोर्टेंस बताई ईजीएफआर की.
जी
सर यहाँ पर जो फॉर्मूले हम लोग और भी हैं एमडीआरडी और सीपी के ये जो आपने बताया ईपीआई वाला, सर इज देयर एनी डिफरेंस बिटवीन द टू फॉर्मूलाज?
हाँ, definitely, you know, the earlier stages of EGF, you know, stage 1, stage 2, the CKD EPI formula is definitely much more accurate. So that's why the current recommendations are by the international societies to use the CKD EPI. And for you, it is just the calculator is there. So whether you want to use the MDRD or EPI, you just have to choose the right calculator. It is equally simple, I mean to say.
Okay. Thank you, sir.
Any other question from the audience? Our both speakers happy to answer your question. I think there is no any question. I thanks to Dr. Sanjeev Gulati sir, who has presented the early diagnosis
Sir,
of
there
CKD.
There is one question in chat box, sir. Gulati sir, there is one question in chat.
Yes.
Renal diseases in COVID patients. Okay. Now, yeah, that is a very practical question. How does COVID affect the kidney? So COVID can cause proteinuria, and the data suggests about 60-70% of these patients can have proteinuria, 20-30% can have acute kidney disease, and there can also be an acute worsening of underlying kidney disease. So this is seen in about half. So of half of all patients, anywhere between 50-70% of all CKD patients develop worsening of kidney function if they develop COVID.
Okay.
So always screen your patients for proteinuria as well as EGFR.
I would like to add one more thing. In addition to COVID, there are complications of vaccination also. There are few reports of proteinuria after vaccination. So we have to be careful about that also. So if a patient presents suddenly a few weeks or days after vaccination with problems, we should evaluate for kidney disease.
Okay. That's great. Now, thank you, Dr. Sanjeev Gulati, sir, and Dr. Mustaqim. You have given the topic completely, and early diagnosis of management and the renal replacement therapy in patients who are having CKD. Thank you very much. And thanks to Fortis people, Mr. Narendra, who have arranged this meeting.
Thank you, sir. Thank you so much.
Thank you. Okay. Goodbye.
Thank you, Dr. Vipin, Dr. Vaishnavi. Yes. And
Thank you, Dr. Sanjeev sir and Dr. Mustaqim.
Thank you everyone. Good night.
हम लोग बहुत जल्दी आपको physically भी देखना चाहेंगे.
No, sure. We are looking. If the things are okay, we are planning a physical meeting next month.
Okay.
If the COVID situation remains, Narendra is there. I think he will try.
Yes, sir.
With you all. If the COVID is under control, then God willing, we'll see you next month.
Okay.
Thank you.
Okay, sir. Thank you, sir. Thank you very much.
Thank you. Good night.
Good night.
Good
Good night, sir.